SARS-CoV-2 is creating a havoc around us. We are all struggling to deal with COVID-19, the new pandemic. No one can claim reasonable level of evidence for management strategies. China faced the crisis as it emerged. The first affiliated hospital has produced this. It is expert advice based on first-hand experience. It reflects the daily experiences of staff over a period of 50 days when they managed 104 confirmed COVID-19 patients, including 78 who were severe and critically ill. This is neither a verification of authenticity nor an endorsement of efficacy of these recommendations. This is a review targeted at healthcare professionals globally to discuss, debate, compare and contrast with other international and local guidance to appreciate and improve practices in dealing with this pandemic. So what is in it? The handbook tries to cover the entire breadth of COVID-19 hospital management, starting with redesigning the hospital structure and manpower distribution to facilitate isolation and segregation of patients, PPE measures, disinfection recommendations, digital supporting the epidemic, elaborate diagnostic strategies and possible therapeutic options, emphasizing on multidisciplinary care, fundamental critical care principles, high standard of medical and nursing support. You are listening to the EM Draft COVID-19 series, Learning from the Chinese Experience. This is the first part, summarizing the handbook, focusing on key aspects. The principle for redesigning is 3 zones and 2 passages. The hospital is divided into a contaminated, a potentially contaminated, and a clean zone. 2 buffer zones run between the contaminated and potentially contaminated zones. An independent fever clinic with an exclusive one must be present outside the hospital entrance. All areas labeled and well demarcated. Standardized flowcharts and full-length mirrors should be available to assist appropriate PPE use. Infection prevention and control technicians appointed to supervise and prevent contamination. Measures should be taken to limit overcrowding and visit duration. This may include allowing only patients into waiting area, investing time and resources for digital healthcare, for example, online triage screening and preventive advice, artificial intelligence, cloud-based hospital system, and electronic access to healthcare notes from QR codes. In the waiting area, masks must be worn by patients with fever or respiratory symptoms. The pre-examination and triage area must have strict criteria to segregate suspected COVID-19 patients, who should be streamed to a separate diagnostic and treatment zone where they undergo the nucleic acid testing for COVID-19. So, who are the COVID-19 suspects? Patients with 1 epidemiological criterion and 2 clinical criteria, or 3 clinical criteria without any epidemiological history, or a patient having only 1 or 2 clinical criteria in the absence of any epidemiological criteria, but radiological imaging cannot be carried out. Then expert consultation can classify them as COVID-19 suspect. Of the suspected patients, those with 2 negative nucleic acid tests in a 24-hour interval without further clinical suspicion can be identified as not having COVID-19. Additional testing is needed every 24 hours to confirm until clinically excluded. Epidemiological criteria are within 14 days of onset of illness, travel to a high-risk area, or history of contact with a person having positive NAT, or direct contact with patients having fever or respiratory symptoms from high-risk regions, or clustering, which is defined as 2 or more cases with fever and/or respiratory symptoms occurring at places like homes, offices, school classrooms, etc. Clinical criteria are fever or respiratory symptoms, CT imaging features of COVID-19, a normal or decreased white cell count in the early stage of disease, or the decrease in lymphocyte count over time. The patients identified as suspected or confirmed need to be streamed to isolated areas with limited access. where a separate standardized care would be provided within negative pressure wards. Suspected patients need to be in separate ensuite rooms, whilst confirmed patients can be kept together in the same room with a bed spacing of at least 1.2 meters. Patients should not have visitors and electronic communication options must be available. Staff should be grouped into teams, with treatment, examination, or disinfection roles divided amongst members. Teams in contaminated zones should work no more than 4 hours at a time. Standard regimen for personal hygiene should be followed before the team goes off duty. Frontline staff working in isolation areas should live in an isolation accommodation. They should be provided with nutritious diet. Health status should be monitored and recorded each day, including body temperature and respiratory symptoms. Medical and psychological support must be provided. Screening with NAT should be done in case of fever or respiratory symptoms, and the staff should immediately be isolated. After completing their duties in isolation area, staff should first have NAT. If negative, they should be collectively isolated for 14 days before returning to normal life. Prior to assigning staff, they need to be educated and assessed on using PPE appropriate to the area of their work. Personal protective equipment. Level 1 PPE is for pre-examination triage general outpatient departments and comprises of disposable surgical cap, surgical mask and gloves, work uniform and disposable isolation clothing if needed. Level 2 PPE is for fever outpatient department, isolation ward area including the isolation ICU, non-respiratory specimen handling of suspected or confirmed patients, imaging examination of suspected or confirmed patients, cleaning of surgical instruments used with suspected or confirmed patients. On top of level 1 PPE, this adds on medical protective mask N95, disposable medical protective uniform and goggles. Level 3 PPE is aimed at performing operations like tracheal intubation, tracheostomy, bronchofibroscope, GI endoscope, or procedures on suspected or confirmed patients where there may be spray or splash of respiratory secretions or body fluids or blood, or when staff perform surgery and autopsy for these patients, or whilst carrying out nucleic acid tests for COVID-19. In addition to level 2 precautions, a full face respiratory protective device or powered air purifying respirator must be added. Apart from these precautions, it should be noted that all staff in the healthcare facility must wear medical surgical masks. All staff based on level 1 PPE, but in areas of higher risk like the emergency department, infectious diseases department, respiratory care, endoscopy, bronchoscopy area, etc., must upgrade their surgical masks to medical protective N95 masks. Staff on level 2 protection must wear a protective face screen device while collecting respiratory specimens from suspected or confirmed patients. Diagnostic criteria to confirm COVID-19 should take into account the epidemiological history, clinical manifestations, lung imaging, results of SARS-CoV-2 nucleic acid detection, and serum-specific antibodies. This is a new disease faced by humanity. Systematic analysis by close monitoring of patient status, progress of disease and complications, coupled with collaborative multidisciplinary input despite segregation of zones, facilitated by video conferencing and other technologies, forms the basis for sound expert opinion, leading to a personalized management plan for each COVID-19 patient, so that proactive interventions can be carried and clinical deterioration can be prevented. Nucleic acid detection by PCR is the preferred investigative modality. SARS-CoV-2 preferentially proliferates in type 2 alveolar cells. Hence, lower respiratory tract specimens have a high positive rate of nucleic acids. Patients with positive respiratory NAT are associated with positive nucleic acids in 50 to 60% of fecal samples and 30 to 40% in blood. Urine sample has a very low positivity rate. The peak of viral shedding appears 3 to 5 days after the onset of disease, which means negative tests at the beginning do not rule out COVID-19. Antibody detection of serum-specific IgM or IgG antibody titer in the recovery phase can be more than 4 times higher than that in the acute phase. This can be used as a diagnostic tool for suspected patients with negative nucleic acid detection. During follow-up monitoring, IgM is detectable 10 days after symptom onset and IgG is detectable 12 days after symptom onset. The viral load gradually decreases with this increase in serum antibody levels. Indicators of inflammatory response can be useful. Procalcitonin usually does not elevate in COVID-19. Its rise usually denotes secondary infection. C-reactive protein is generally elevated in COVID-19. Poor prognosis and disease severity is indicated by an elevated D-dimer, low total lymphocytes at the beginning, progressively decreasing peripheral blood lymphocytes, and increased expression levels of interleukin 6 and 10. High-resolution lung CT is highly preferable in COVID-19. Early stage of illness is characterized by multifocal patchy ground glass opacities mostly parallel to the pleura. Lesions are mainly located in the lung periphery, subpleural area and bilateral lower lobes. Few ground glass opacities show subpleural reticulation due to septal and interstitial interlobular thickening and are termed as crazy paving. Over 7 to 10 days, the lesions enlarge and increase in density, usually displaying air bronchogram sign. In critical cases, whole lung density develops, leading to white lung. Patients with typical CT pulmonary manifestations must be isolated and undergo continuous nucleic acid tests, even if initial NAT for SARS-CoV-2 is negative. Chest X-rays are usually reserved for critically ill and immobile patients. Bronchoscopy is especially useful in mechanically ventilated patients to collect lower respiratory specimens. A classification is proposed based on disease severity. Mild cases with no signs of pneumonia, moderate cases where patients have fever and respiratory tract symptoms and pneumonia on imaging. Severe cases where patients have tachypnea more than 30 per minute, oxygen saturation of 93 or less at rest, a PF ratio of arterial pressure of oxygen and inspired oxygen concentration of 300 or less, or lesion progression on imaging of more than 50% within 24 to 48 hours. Critical cases are those patients requiring mechanical ventilation for respiratory failure, or patients in shock, or presence of other organ failure requiring ICU care. Critical cases can further be subdivided as early, middle, and late stage based on worsening oxygen index and lung compliance. Early stage has a better prognosis through active antiviral anti-cytokine storm and supportive treatment, whereas the late stage, characterized by diffuse consolidation of both lungs or multi-organ failure, carries a significant mortality, where ECMO might be a treatment option. There are no evidence-based specific treatments available yet. The basic antiviral regimen is lopinavir-ritonavir combined with Arbidol. Chloroquine phosphate can be used when basic regimen is ineffective. Other treatment options include interferon nebulization within negative pressure wards, artificial liver support system for blood purification to diminish inflammatory mediators and cytokine cascade, thereby helping with shock, hypoxemia, and respiratory distress syndrome. Short-term use of glucocorticoid regimens has been used to inhibit cytokine cascade in severe COVID-19 pneumonia. High-flow nasal cannula oxygen therapy is recommended for patients with oxygen saturation less than 93% or PF ratio of less than 300. Patients should use a surgical mask whilst on HFNC. NIV is not encouraged for COVID patients, but depending on severity, they may require invasive ventilation. Prone position ventilation is usually well tolerated and used for patients with a PF ratio less than 150 or obvious imaging manifestation with appreciable improvement in oxygenation and lung mechanics. Intubated patients are kept prone for 16 hours a day and spontaneously breathing patients for 4 hours at a time. Fundamental critical care and nursing with effective WAP bundle, maintaining balance of intestinal microecology and nutritional support play a crucial role in recovery. Strict fluid balance is paramount as excessive fluid burden worsens hypoxemia in COVID-19. It is important to be vigilant to prevent and treat secondary bacterial and invasive fungal infections. Extracorporeal membrane oxygenation can play a role in the treatment of critically ill patients with severe respiratory failure. COVID-19 can progress rapidly into severe and critical illness due to direct target organ damage by pathogens. Passive immune antibodies can effectively neutralize this and block the subsequent immune pathological damages. Plasma can be obtained from patients who have recovered, whose lower respiratory NAT remains negative for more than 14 days. Traditional Chinese medicine principles have also been used to formulate a separate classification of COVID-19 and institute treatment strategies to improve curative efficacy. It is necessary to be mindful of adverse effects and interactions of the several drugs and therapeutic measures used for COVID-19 patients, as well as with medications used for underlying diseases which may cause or worsen organ damage. Proactive and anticipatory packages should be available for COVID-19 patients requiring hospitalization to provide them with psychological and rehabilitation support. Discharging recovered COVID-19 patients is a multidisciplinary decision. Respiratory nucleic acid tests must have been twice negative in an interval of at least 24 hours. Patients must be afebrile for at least 3 days. Respiratory symptoms and lung imaging should have improved. They must be able to maintain an oxygen saturation of more than 93% without assisted oxygen inhalation. Patients discharged must be isolated at home for 2 weeks. They must be in an independent living area with frequent ventilation and disinfection. They should avoid contact with infants, elderly, and the immunosuppressed. They and their family members must wear masks and wash hands frequently. They should monitor any changes in clinical condition and body temperature twice a day. A designated specialized doctor should follow up discharged patients. Telephone follow-up should be arranged 48 hours, 3 months and 6 months post-discharge. Outpatient follow-up must be arranged at 1 week, 2 weeks and 1 month post-discharge to check liver and kidney functions, blood tests, sputum and stool NAT, and to review pulmonary function or lung CT scan according to patient's condition. It is interesting to note, during the period this handbook was produced from the first affiliated hospital, isolation, diagnosis, treatment, protective measures and rehabilitation all started from scratch. No staff were infected, there was no misdiagnosis or patient deaths. As the foreword to this handbook affirms, the real remedy for this pandemic is not isolation but cooperation. We have gone through the summary of this review. Subsequent parts detailing treatment, disinfection regimens, nursing aspects, and digital healthcare are planned to be available at www.emdraft.com. Thanks for listening. Please share the information and kindly connect for any comments or opinions.